this type of facilitation, but I was very fortunate that they supported me in this. The next challenge was about team building. There were professionals who were aware of dysphagia and were very proficient with assessment and management, but they were not confident in conducting a dysphagia support group. They were not confident that how they will carry this activity out. Again, after formulation of the team, after teaching and training using the material provided by National Foundation of Swallowing Disorders, we moved toward the publication of that material and what we can say that telling people that we are going to introduce this support group. We started publishing it on different Facebook platforms. We started using different types of standees. We started meeting different consultants and letting them know that we will be offering a support group soon. We then started the registrations, and then again there are some findings which I would like to share with you. When the process of registration started, 67% of the calls that we received were from the speech pathologists. They wanted to join support group to learn dysphagia, which was very surprising. But it was also something which we were expecting, that as we don't know about support groups, speech pathologists were equally unaware what support group exactly is. So they basically contacted on the provided number to register for dysphagia support group to learn about dysphagia. It was good to know that our speech pathologists are interested in this specific disorder and they want to learn, but it became a big challenge to reach the actual audience that we were trying to target. Another observation was that only 22 patients called on the provided numbers to register for dysphagia support group, out of which 6 contacted after knowing about this support group through social media. 1 was referred by medical specialists, 7 were referred from neurology department, and 8 of them were referred to us from rehabilitation services. So we can link this finding with the current evidence that is available, that our health professionals are not aware about the role of speech pathologists in treating dysphagia as a multidisciplinary team professionals. Another finding was that out of 22 patients who contacted us to be registered in dysphagia support group, only 14 registered for the dysphagia group. And in N, only 11 of them joined the dysphagia support group. Out of which, 1 patient was diagnosed case of motor neuron disease, 6 were stroke patients and having dysphagia, and 4 of them were diagnosed with Parkinson and dysphagia. Another barrier which was noticed during this support group activity was of transportation. 36.36% of the patients who contacted to join dysphagia support group requested to provide transport. So as we go through different researches, it is evident that in Pakistan, commute is a very major issue for patients to reach the rehabilitation services. So was the case with us when we introduced the dysphagia support group, that patients were having difficulty in commuting and reaching the support group. Another finding was that there is ample evidence available that we can introduce these support groups online or through using different digital platforms. But unfortunately, in Pakistan, the availability of net, the electricity glitches and other problems can lead to difficulty in introducing this group online. Misconception was there. Many of the patients contacted and asked, will they be paid for this support group? If they will come, if they will bring their patient to the support group, will we be paying them something? And it was very sad when we received this type of calls that in Pakistan, unfortunately, we are ready to sell our disorders or our patients for the sake of money. Another problem was that patients were looking for a quick fix. They wanted to know, will we be offering them some medicine to cure dysphagia during the support group? Will we be giving them some free consultation or follow-up session coupons during the support group? So what we can say is that it was, we can conclude that there is limited health literacy in Pakistan, because people who were contacting us for support group were not aware what exactly we are offering them. Another thing which was very surprising and what we can say is saddening was that only one female participated in the dysphagia group and 10 males were there in the dysphagia support group. This is again, we can correlate it with the existing findings that in Pakistan, unfortunately, health facilities are not equally available for the both genders, and we can see that discrimination in this dysphagia support group as well. We can also relate this thing with the cultural issues and the stigma attached to the problem. Patients who were with the NG tube were reluctant to participate and being photographed during the dysphagia support group. Patients who were having PEG tube were more confident during the support group and participating more as compared to patients who were with NG tube. What we hope for the future is that we will be having better services for patients having dysphagia. We will be having better setups where we will be providing support groups for not only dysphagia but other patients as well. I would also like you all to consider this thing that initially some things may not look very important to us, but if we start working on them, we come to realize that these are the things which are very crucial for the patients who are suffering from that problem and the family members who are dealing with such patients. In the end, I would like to play a small video. I'm not sure if it will be played here or not, although I requested the media. It's just a 1-minute video from our dysphagia support group.
Good afternoon, everyone. Assalamu alaikum. My name is Mahmoud.
It's okay, take your time. Abhi hai mera time. एक स्लाइड बैक जाएं. So this is a small clip from the first dysphagia group which was introduced in Pakistan, and I would like to share it with you if we can play it here. Otherwise, I'll share the link. It is available on the Facebook page, and anyone who is interested in watching it can watch it from there. Thank you so much.
Thank you, Madam Faiza, for this informative session of dysphagia. Our next keynote speaker is Dr. Humaira Shamim Kiani. She has a dedicated career in the field of speech-language pathology. Her academic achievements, including a PhD in rehabilitation sciences, are truly remarkable. Dr. Humaira's commitment to advancing the field is evident through her accomplishments such as conducting the first aphasia certification course in Pakistan and achieving registered behavior technician status. She is also a dedicated member of Aphasia Stroke Association and currently serving as Finance Secretary of Pakistan's Speech and Language Pathology Association. Dr. Humaira has made significant contribution with numerous publications in national and international journals. Her dedication to education and research is further understood by her position as the head of Department of Speech and Language Pathology at Rifa International University, Islamabad. Today we have the privilege to learn from her on the topic of prevailing and advances in speech and language approaches regarding adult neurogenic communication concerns in Pakistan. Please welcome.
Bismillahirrahmanirrahim. Assalamu alaikum everyone. Meanwhile, it's going to be display here. I'm Dr. Humaira, and a very good afternoon to the distinguished guests, especially our international keynote speaker, our national speaker, the lovely audience, and my dear students. Today I'm here basically to talk and discuss on the topic that is prevailing and advances in speech and language approaches regarding the adult neurogenic communication concerns in Pakistan. Speech and language pathology is emerging yet a rapid growing discipline in the Pakistan, and it's basically considering the welfare of the patients from the last few decades. The intense need and demand of the speech language pathologists has been recognized to serve in the diverse for the individual that have concern to the communications problem, and it's estimated about that 23 million population in the Pakistan are with the communication difficulties and the concern.
There is some problem in the IT system, so we have to wait for the 5 minutes. Thank you.
Actually, wait is very difficult. Either for the presentation or for the anything else, you want to talk or you want to listen to someone else, and it's same for me as well, who isn't standing in the stage here. I'm talking about the communication. Basically, there's about 230 million population in Pakistan, across the Pakistan, who have the communication concerns that are based on the articulation, phonation, and the voice, and also related to the adult neurogenic communication encompasses the aphasia, dysarthria as well. So keeping this number, it's significant, and these number, you can imagine how the demand of SLP services in the Pakistan. So meanwhile, when it's going to the start, I'm telling you about my topic. As we all moving forward, the adult neurogenic, actually due to the lacking of the time, they told me that I have to continue my presentations, and later on maybe you have see the display of my slides as well. But listen to me, although it's very difficult, audio without vision, especially speech therapists know this better. But it's okay, tolerate me. Adult neurogenic is basically a concern that is most prominently due to the acquired any conditions secondary to nervous system, and the patient with this have difficulty to exchange information and to conversate with each other. As we notice on the risk factor, age is considered to be the most prominent risk factors for the neurogenic conditions in which the Alzheimer's or Parkinson's are on the priority. Among these, there are also different neurogenic conditions like traumatic brain injury and some other problems, but the stroke becomes the most prominent among these all. Neurological disorder rank a leading cause of the disability globally, accounting for the 276 million disability adjusted the life years, and second leading cause of death, resulting 9 million deaths in the world. Dysarthria is the common type of the neurogenic disorder in the geriatric population, and it is due to the resulting from the impairment of the muscle tone to produce a speech. And basically they hit some speech parameters, that is the respiration, phonation, articulation, prosody, and the rate of speech. If the patient is affected from one of the any parameter, they can be difficulty to have the intelligible speech, because they are both work in the, all systems are work in the coordinations. So moving forward, dysarthria is therefore not only a major speech disorder that are resulting to any impairment related to basically language or any structural deformity like the cleft palate and any sorry, it's basically some technology issues here. And also, it's not apraxia. As we know, the apraxia is the programming and the planning difficulties, and it's also different from the aphasia that is basically hitted the language content, not the errors or the articulations. And if we are looking globally, the prevalence about the dysarthria, as we're talking about the neurogenic conditions, there are the several neurogenic conditions that have prone to or cause the dysarthria. And with the traumatic brain injury, it is observed that 10 to 65% are basically the patient with the traumatic brain injury have experienced the dysarthria. Same with the Parkinson's. If we are moving with the patient with the Parkinson's, they are 70 and the 100% among these. Up to the between 25% and 50% are with the MLS. And then the patient with MLS are 30% across the globe. Then further, if we move ahead, the dysarthria can be further classified and divided according to the specific the symptoms and their perceptual characteristics according to the area of the lesions. And these are like, some have the spasm, some have the spastic, flaccid, ataxic, upper motor neuron, hyperdysarthria, and have more than one of these, mix of one or two due to the some specific key features of the speech and the area of basically lesion. If we are taking the patient for the assessment of dysarthria, we have the main key component of speech problems. So we have to take a, no, it's not working basically here. I'm just
Okay. So, okay, continue.
So we take this major component. So, yes, I know. No, this one. Thank you. As a speech therapist, I guess my rate of speech is faster than the technology is displayed here, but it's fine. Aphasia is another one of the major cause that hit the geriatric population secondary to the neurogenic disorders and the neurogenic conditions, in which basically is a disturbance of language formation, either the comprehension or the expressions due to the one of the major hemisphere, that is the left, which is dominant and responsible for the language. It is mostly commonly a clinical feature that hit the functional impairment and also effect and the negative effect on the quality of life of the patients can have the must be differentiated from the other motor speech like dysarthria and mutism and dysphonia as well. If we are looking the global prevalence of aphasia, it is noted that about 0.1 million the patient per year the patient are reported, and the incidence rate of the aphasia is ranged from the 30% to the 40%, and 64% are stroke survival with the communication, in which 12% had the dysphagia. ये बंद हो जाएगा.
Okay.
Come close.
आप इसको भी ऐसा करिए, थोड़ा सा curve में ना
16 to 93% are basically with the aphasia and the communication disorder. If we are looking at prevalence in the Pakistan, the stroke is considered to be a most prominent and the leading cause for the aphasia, and in which the 250 per 100,000 patients, which means 350,000 new cases per year, and in which 54% are with the post-stroke, and the rate of the survival among them are 25 to the 40%. Aphasia is also further classified that depends on basically the feature of the fluency, non-fluency. Patient can speak or express fluently and not fluently, or can have the ability to repeat, or they have the auditory comprehension, or the compromise. So on these bases we can differentiate and classify aphasia like the Broca aphasia, Wernicke aphasia, in which the Broca the patients are non-fluent, and in the Wernicke, as you see here with the Wernicke aphasia, the patients are with the fluency, but they don't have the comprehension about the content. They are just fluent about their own speech, and same with the other types of dysarthria as well. If the patient comes for the assessment, we have to look on these following parameters to assess the aphasia client. That is the spontaneous speech, repetition, comprehension, naming, reading, writing skills, gestures, fluency of the patient, and also we assess on their automated speech. The clinical eval is very important for the patient, and they have some key element parameter why we are going toward the evaluation and assessment of the patient, because they also told about the impairment, severity about the problem, and classified the either it's going toward the fluent side or the non-fluent side, or the patient have the compromise, comprehension and severity level as well, and also it's connected with the factor time and the intelligibility and the memory of the patient. If we are looking for the assessment of the parameter of dysarthria, we have to look on some key perceptual characteristics about the subtypes of dysarthria, about the component of the speech and the severity level, and also identify some other processes that can involve in it and contribute, like swallowing problems or other language concerns as well, and also have the impact on the speech intelligibility. So we can look on it and to make the patient more functional in their communications and get back to their normal routine according to the language perspective. In Pakistan, we have some standardized, there are lots of standardized tools who assess dysarthria and aphasia. I am talking specifically in the Pakistan. We have across some standardized diagnostic tool we are used in our clinic setup for aphasia and dysarthria. These are some listed name here. That is the Boston Diagnostic Aphasia Examination, that is the Western Aphasia, Boston Naming Test, and the Comprehensive Aphasia Test, then the Quick Aphasia, Franchise, Battery, Robertson. You're all familiar with these names, and maybe most of you are using it in your clinic. Basically, the cultural sensitivity is become increasingly important in the diverse countries, especially in the Pakistan. We have to take the individual cultural background and the linguistic background when we take it in the assessment, or either we are making the intervention goal that based on this assessment. So keeping in this, although speech and language pathology was established later as compared to the elsewhere, but keeping in that fact and overcome to the barrier of linguistic and the cultural background, we are working on it and take the initiative to develop a culturally appropriate and translated some tools, so we get the more prominent and more relevant to the diagnosis of aphasia and dysarthria as well. These are some tools which we are basically developed, and some are in the phase of validation after the development, that are related to the aphasia and the dysarthria assessment tool, Urdu assessment tool for aphasia, naming test, stroke aphasia, quality of life, action picture test, quick aphasia battery. There is a communication confidence rating scale, and also dysarthria impact profile and development of screening test for dysarthria. There is an increasing demand of evidence-based practice in SLP, so we are in touch for the most currently and the evidence-based approaches that use and deal the individual and based on the need of the individual priority. So there are some theoretical-based therapies we are taking, and these are some names for the therapies, but they are specific. Some is for the expression of the patient, deal with the expression, some with the comprehension, and some have to enhance their intelligibility skills. Some are working for the articulation, and some are most prominently to enhance their writing and their reading skills. That is also the mean of communication for the aphasia client they can use. Advancement in the speech or in the any basically profession is very prominent and very effective, but though challenging as well. There are some computer-aided communications and the language therapies that use for the patient specifically for the aphasia, and according to the evidence, they also affect and come out with a positive result of patient in their reading and writing skill, as well as they work positively with the chronic aphasias. Above that, we have some different automated boost articulation therapy. There is a virtual therapy that is specifically made for dysarthria and motor speech of patients. They have the therapist have to target the sound and the verb, and patient have to pick it from here, get the modeling, and also practice on it and get reflection from this, basically the game and the virtual therapy applications. There are some other mean of interventions for the patient for the advancement. These are based on the gadgets, so patient get trained and become independent to take a session by their own. And these are some applications which are also used for the language for the patients. These are the advancements of the therapy, that is the reading therapy, text, language therapy, and the game-based speech therapy training. But all have some limitation, and this limitation constrained us to make our intervention protocol, intervention plan for those patients who have only the primary language of the Urdu, because all these are in English language and can be accessible and usable for those patients who are the bilingual and both with the Urdu and the English. So keep in that mind, we are also develop one of the verbal expressive skill management program in Urdu in Pakistan, which are dealing all the parameters of aphasia, and this application is basically working with the client, and specifically they have the different level of difficulty for each parameters. The patient, the target for the patient is set. If patient is affected for one parameter, they have to be achieve their 3 level of difficulty, then they can move forward. And it's basically start from the sound, word, simple phrase, a simple sentence, till the connected speech. And this content is totally based on the Urdu, and is, you can see like these and they have the cue for the audios as well as the videos, and also have the writing option. If the patient want to the type, if they can't understand, they can write and get the answer back to verbally. Same for the dysarthria, we have another Urdu language management applications that also take care all the speech components. I have talked later in the previous slides, and through this the patient, and also with the Urdu content, and the patient get their respiration, their phonation, their intonation pattern, and there are basically some time frames, some practices when the patient hit that, and they get the proper intonation, their pitch variations, their voice quality. Through these they can maintain and get the benefited. Apart from these, there are also some therapies that are dealing with direct the patient, the feeling of the patient about their concerns, their problems. They are basically, one of them are photo voice therapy. This research is also conducted in the Pakistan. The patients get pictures and give the voice or talk to that picture, and it's totally related to their basically reflection and emotion at that time when they are taking the picture. And this is conducted on the aphasia, and we make it like the aphasia talk. You can see their pictures. These pictures are basically taken from the patient. Patient get trained on the through cameras, and they get pictures when they are going for the outing or at the home or anywhere else, and the follow-up session were taken. And these are some narrations from the patients, and you are looking on the pictures, and these narrations are come out like in the first picture they said that they are the lack of support. In second picture you can see that someone have given the support to walk the patients, and according to them being healthy is a blessing. And then there is a basically evening scene, and the patient tell about their feeling about that basically picture. I'm talking about the slide which I showed now. Apart from this, there are some other approaches that can be for the caregivers, where we train the caregivers of the patients for the aphasia and dysarthria, for the adult population, geriatric populations, because they have lots of time with their partners, with their family sports, with their members, other members. They are connected the whole day, so they get back to their normal routine and communication at the maximum optimal level through these. So the live participation approach with the aphasia, we take it in here, and we make a protocol of all these in Urdu, and we train basically the partners and the family members and the relatives of the professionals who directly or indirectly involved with the patients. So to get better and get back to the community, which a person with aphasia living, train and provide the services, measuring of the success of result and the enhancement of the changes. It also recognized by the lifelong participation approach with the aphasia. LPA focus on the availability of resources and services at all the stages of aphasia. Then we have another protocol, same for the caregivers, and it's called the name of ASK. ASK is basically action, success, knowledge. And through this we train the client about the awareness and how, if the patient wants to communicate either with the verbally or non-verbally, how you motivate them, or you use these kind of non-communicative devices to communicate with your basically partner or any family members who are in the sport group of that member. This research is also done in the Pakistan, and the Urdu protocol is developed and used for the client as well. As we are talking in the morning session, there is a talk on the AAC, and yes, in the Pakistan there is a lot of challenge how to use the AAC devices from the low to the high tech. So keep in that loop and gap to overcome these gaps. We also have a task that is basically the test of aided communication symbol performance for the Urdu, and it also for the geriatric population, and they get the culturally appropriate and benefited from all this. During the paradigm shift, although the tele-rehabilitation is not new, it's basically practicing across the globe before the pandemic, but it's more pronounced during the COVID-14 and the paradigm shift. And this shift is in the original mean in the Pakistan. As we are moving toward the teletherapy, speech language pathology services are giving through the tele-rehab, remote language pathology, that using the video conferences and the telephone and get the therapies and the patient to benefit the patient who can't come face to face and communicate to their partner, their community, and get the functional life back during the COVID when they are not coming physically for the sessions. And these are basically researches. I must to tell you that these all researches are in the Pakistan, and our students, our alumni, RIFA alumni are doing these researches in the Pakistan, and basically RIFA University is the pioneer to taking the edge and the initiative, the speech and language pathology degree. So we also the pioneer to initiate and start the researches that are culturally appropriate and also related to our linguistic purpose, fulfill the linguistic purpose of the client. So we make, and we are also want to do more and more for the betterment of the community and our field as well, and patient get benefit. So at the end, I'm leaving my talk with some future considerations. The profession of speech language pathology needs to move beyond education only interventions. Important to identify the local implementation barriers so that intervention can be targeted and overcoming the barriers. There is a further support for tailored assessment and intervention that use other methods, not only education, to address belief about the capabilities and social influence. And we must have the assessment and interventions tools that are based on more local languages for the patient other than Urdu. There are also different regional languages and with the different, same language with the different dialect as well. So this is from my side. Thank you so much. Have a good day. Thank you for the listening.
Thank you, ma'am, for showing patience during the technical inconvenience. Now let's move towards our next keynote speaker, Professor Dr. Muhammad Salman Bashir. He is currently serving as the Dean and Professor at the School of Health Sciences, University of Management and Technology, Lahore. He has extensive experience including roles as Head of Department of Physical Therapy, Associate Professor, Associate Dean for Postgraduate Programs and Research, and the Head of Department for Clinical Services and Training at various prestigious institutes. Professor Salman has achieved his PhD in Physical Therapy from Tehran University of Medical Sciences. He has an impressive portfolio of more than 80 research publications in both national and international journals. With a dedicated career spanning years, Dr. Salman Bashir has emerged as a prominent figure in the field of physiotherapy. Throughout his career, Dr. Salman has demonstrated a relentless pursuit of knowledge and excellence. Please welcome Professor Dr. Muhammad Salman Bashir to present on the topic of challenges to implementing artificial intelligence in rehabilitation practice.
Thank you. अब दोनों पे चलेंगे इंशाल्लाह. Okay. ठीक है. Thank you. Easy से? Okay. Thank you. Assalamu alaikum. Good afternoon. First of all, I would like to congratulate the Rifa International University Higher Management, especially Professor Dr. Asghar Khan and Dr. Sayyid Shakilur Rahman and his dedicated team to continue the trends for arranging Rehabilitation Sciences Conference. I'm working at University of Management Technology. Is a top-ranked university among all private sector university of Pakistan, more than 30,000 students and more than 700 faculty members. Now I would like to come to the title of today's keynote, Challenges to Implementing the Artificial Intelligence and Rehabilitation Practice. It is according to the Sustainable Developmental Goals of UNICEF 3, Health and Well-being, 4, Quality of Education, and 9, Innovation and Advancement in the Technology. The background, integration of the artificial intelligence in the rehabilitation practice is challenging due to the perceptions, lack of knowledge, willingness, readiness, and ethical consideration. Professionals are reluctant to inculcate the artificial intelligence in practice due to the fear of replacement. Before implementing the artificial intelligence into the practice, there is a dire need to identify the challenges to implementing the rehabilitation practice. Results. A pilot study was conducted in Pakistan from January 2023 to June 2023 to understand the problems faced by the therapists and the students about the artificial intelligence. The results showed that the lack of education about the artificial intelligence in the undergraduate as well as graduate curriculum. Therefore, the physiotherapists will not be enabled digitally, and then they will be either reluctant or afraid to adopt the artificial intelligence. Professionals are unable to incorporate the artificial intelligence into the practice due to the training, lack of training. Here we will share that the experience from novice practitioner to the expert therapist, and we have collected the data from all major provinces of the Pakistan, Balochistan, KPK, Punjab, and Sindh. The willingness to receive the more information or artificial intelligence. Here you will see the 10%, round about 11% of the population of the physical therapists who are not more interested to take the more knowledge about the artificial intelligence. And now we will see that the physical therapist perceptions regarding the artificial intelligence, they think about that, the reducing the therapist workload, they will ease the patient care, they can helpful into prevention of the diseases, And they will think about that the prediction of the disease is more helpful if we adopt the artificial intelligence. Goal setting will be more easy. Assistive technologies that definitely will enhance your practice. Diagnostic tools will help you to diagnose the diseases. And definitely the education enhancement is also a very key feature. Human resources, we can think about that and increase the productivity, improve the patient quality. And teaching of the artificial intelligence application should be taught in the rehabilitation curriculums. Here we have recently revamped the curriculum of the UMT, as well as we have also all the universities are following the HEC guidelines regarding the technology advancement in every field, especially in the clinical sciences and as well as other disciplines. The primary concerns regarding the implementation of the artificial intelligence in the healthcare system, inability to understand, and definitely the problem that we are facing regarding the lack of training and the unpredictable situations are the major concerns regarding the artificial intelligence to cooperation. Now I would like to conclude. This is the today's message, and hopefully the senior therapists are very afraid regarding the artificial intelligence. Although the physical therapist will never be replaced by the artificial intelligence, but technology-enabled physiotherapist will absolutely replace the physiotherapist who is not technology-enabled. And this is the statement that was given by the James Morey in the APTA regarding the Digital Physical Therapist Summit. And the recommendations, we should include the artificial intelligence and technology advancement in the rehabilitation programs curriculum and conduct the courses, training, seminars for the physiotherapists and students and the other healthcare professionals. Thank you so much from ICI.
Thank you, Professor Salman, for this informative session. Now, let's move towards our next keynote speaker. Dr. Saad Mahmood is an academic and manual therapist in the UK. He completed his graduate study at Cairo University in 1999 and worked clinically and academically in Cairo before moving to the UK in 2004, where he started his academic role at Sheffield Hallam University as a senior lecturer. He has a master in musculoskeletal physiotherapy from Sheffield Hallam University, diploma in manual therapy, and currently pursuing a PhD degree in musculoskeletal physiotherapy at Sheffield Hallam University. He leads the musculoskeletal module within the advanced master program and supervised many master dissertations in the field of musculoskeletal physiotherapy. Today he is going to present on the topic of shoulder management, the lockup approach. He is not with us physically, but we have the recorded session of Dr. Mahmood Saad. Kindly play the video.
Good afternoon, everyone. Assalamu alaikum. My name is Mahmoud Saad, and it's a pleasure to be part of the 4th International Conference on Rehabilitation Science. And today I'm going to talk to you about, in a very short presentation, and I hope it will be more a clinical presentation rather than just theoretical one, about management of shoulder problems, and I will follow a simple clinical approach. I call it the lookup approach. I'm based in the beautiful city of Sheffield in the United Kingdom. I worked for many years at Sheffield Hallam University as a senior lecturer, mainly teaching on the undergrad and postgraduate musculoskeletal physiotherapy program. I have supervised many master dissertations on the field of musculoskeletal physiotherapy. I'm a fellow of the Higher Education Academy, and I'm also have a great interest on the development of professional training on the Middle East, Asia, and other countries in Europe. And next year we are going to Australia and China. So I founded Prime Physio Training UK in 2006, and I also was one of the founders of the Orthopedic Manual Therapy Academy in 2017. I work in my own private clinic for many years and also work occasionally on the National Health Service in the UK. Prime Physio Training UK has 4 offices, 4 official or legal offices in Sheffield, UK, Dubai, United Arab Emirates, Istanbul in Turkey, and in Cairo, Egypt. But we do activities in many other countries through partners like Ghani Physio in Pakistan. We did over 45 activities, even more, in Pakistan since 2018. And it was a pleasure and honor to start a nice movement of professional development in Pakistan since we started a few years ago. And as usual, thanks to Ghani Physio, our partner in Pakistan, for supporting our mission and helping us to spread knowledge. So Orthopedic Manual Therapy Academy is an interest group with the IFOMT, and IFOMT is a subgroup of the World Physiotherapy. So IFOMT is dedicated to the development and setting the standard for education in the field of musculoskeletal physiotherapy. This is Sheffield Hallam University, where I worked for many years, about 16 years now, as a full-time senior lecturer, and we offer a variety of postgraduate programs in musculoskeletal neuro rehab, but also PhD programs. If you are a musculoskeletal physiotherapist, you are a very important professional, because musculoskeletal physiotherapists, they actually treat 25 or 27% of the population, because 25 or 27% of the population will have musculoskeletal problem at least once in their life. And if you think about who's going to manage this problem, it's mainly physiotherapists. So we have a massive responsibility, and we have to be up to this responsibility by having the knowledge and skills to provide our patient with a long-term treatment rather than just focusing on a short treatment or short effect treatment. Management of any musculoskeletal problems has to start with ruling out red flags. If I think about ruling out red flags, I follow a system that I took from my daughter, Salma. She used to play football, and in order to avoid heavy defeat, they used to say, okay, if you are in doubt, kick the ball out. So this is my advice to my colleague. If you don't know exactly what's going on, if you are not sure if this problem is a mechanical problem or not, straight away refer this patient either for investigation or for a medical doctor in order to conduct this investigation. So first of all, safety comes first. Make sure that you rule out any red flags. Examples of red flags could be high temperature, patient with shoulder problem and high temperature. Come on, you have to send him for a blood test and then come back. If your problem is still mechanical, then we can look at it. Night pain, night sweating, constant pain that doesn't change with position or movement, unexplained weight loss, history of breast or lung cancer or metastasis. So all these are basically red flags. So the story of management of shoulder problems has to start like anything else. Subjective examination, physical examination, and then the treatment must include, and this from the Orthopedic Manual Therapy Academy or OMTA point of view, must include what we call the golden triangle. Hands-on therapy, neuro education or pain neurophysiology education, and tailored exercise. Inside this triangle, you can add anything: taping, dry needling, soft tissue release, all whatever, electrophysical agents. But the triangle must have these 3 elements: hands-on therapy, manual therapy, and a tailored exercise, something related to kinetic control, which is one of the courses that will come to Pakistan next year. And definitely education of the patient about that pain is not doesn't mean serious damage, and encourage the patient to move and make the patient understand what's the mechanism of pain. And I'm sure each one of you guys have the skills to deliver the message simply to your patient in a simple language. Okay, I will start my argument by talking about this. Sometimes it's not always capsule. So if you think about this study, this lady had what we call frozen shoulder, and they decided to make manipulation under anesthesia. When the patient was awake, as you can see, the range of movement is very limited and very painful. But once they put her in sleep, she's under anesthesia now. the range of movement is full and pain-free. What does it mean? It means definitely this problem is not joint related. So we can't call every shoulder problem a frozen shoulder. Another point of view that or another argument that I will use to support my discussion today is the convex or concave rule. I know everyone in this room has been told or has been taught about the convex or concave rule. I'm not saying we need to say no, it's wrong. No, but there is a quite few questions mark about the convex or concave rule. So it's not always abduction, the range that will increase if you do inferior glide. It's not always flexion, the range that will increase if you do anteroposterior glide. So what we know now is if you just move the joint, you can, if you just mobilize the joint in any direction, you can increase other directions. So, which is a great news because it means when it comes to shoulder mobilization, we don't need to be very picky and very fussy about the direction of mobilization. We just move the joint, but we have to move it slowly, gently, and in a rhythmic way. Slowly, gently, and in a rhythmic way. Why? Because based on the previous evidence that problems of the shoulder not necessarily is a capsular problem or a joint problem. Maybe it's related to a muscular overactivity, myofascial overactivity. What's the evidence? When this lady was active, was awake, that means that the brain is controlling the process. The brain is sending over recruitment, sending over messages, too many motor impulses to the big mobilizers around the joint. So the joint is not moving because simply the overactivity of the mobilizers will limit the movement. But once the brain is off, once the patient under anesthesia and the muscle activity is off, right? Now the range of movement is higher. That's mean when we move the joint, is not about when we move the shoulder joint, we are not actually breaking down the adhesion or something like that. No, our aim is to just move the joint to desensitize the tissues. We have sensitive tissues. We need to desensitize these tissues. We need to calm down the muscle spindle activity. And we have a strong evidence on that's related to the spine, related to the hip, related to the knee, and related to the shoulder. If you do your movement of the joint slowly and gently, you can definitely affect the motor activity, i.e. improve the activity of the local stabilizer and calm down the activity of the big mobilizers that might limit the movement and make it painful. So I would like you guys to remember this discussion because later on, when it comes to the choice of shoulder mobilization strategies, we have to make it simple, gentle, and rhythmic, and an unloaded position. Unloaded means the patient is lying down, because if the patient is lying down, all the muscle spindle activity is relaxed. So that means you can actually achieve your aim. So this is my point of argument from this. So how to start assessment, or what's your point? What's a look-up approach? Always I start spinal. If the patient has shoulder symptoms, I always start with cervical spine. But first, I always like to start with active range and passive range testing of the glenohumeral joint. Why? Because I need outcome measure. So every time I will do something for the neck, I go back and retest the movement of the arm. I ask the patient about the symptoms around the arm. So doing the active range and passive range at the beginning of your assessment is very important to have an outcome measure, to give you an outcome measure. Okay? Good. So start spinal, go peripheral, and I will explain that in a minute. Start with reduction test and leave the aggressive or provocative test for later. In 2008, 2010, 2018, 3 systematic reviews that have been published in relation to the reliability of shoulder testing. And one of them has been delivered or has been published by myself and my colleagues at Sheffield Hallam University in 2010. And this was a research team led by Dr. Stephen May, the author of the McKinsey textbook. And the result was very clear. Guys, we need to calm down when it comes to shoulder testing. Any assessment, any testing that will not guide your treatment, I'm not interested in something like that. If my assessment will guide my treatment, I will go with it. So what's your point? My point is, if we start our assessment with cervical and thoracic spine range of movement testing, repeated movement testing, then we can, and passive movement testing, actually we can relate the shoulder symptoms to cervical and thoracic spine. What is that? So patient has shoulder symptoms now. And if you moving the arm to flexion is painful. If you put the cervical spine into retraction and the range increases, this is what we call symptoms modification. And it means the cervical spine is part of the problem and the shoulder symptoms is mainly neural. Doing repeat movement testing, the great invention of the Robert McKenzie. If the patient do movement repeatedly to different directions, particularly on the sagittal plane, and the patient's symptoms decreases, that means cervical spine is part of the problem. If you do passive movement, particularly the fantastic lateral glide of the cervical spine, and the symptoms around the shoulder decreases, it means cervical spine is in. If you do neural tension test for a patient who have symptoms while combing the hair, and you do the ulnar nerve tension test and it's positive, or a patient who have symptoms getting getting the wallet, radial nerve tension test, or patient has a problem opening the door, or pain on the shoulder opening the door, median nerve tension test. If you do the neural tension test and it's positive, it means that part of the problem around the shoulder is related to the neural mobility and related to cervical spine. So symptom modification, and I give you example of this, which is moving the neck or relocating the neck in one position, and the shoulder symptoms changes. That means cervical spine may be on. And the same for thoracic spine. Ask the patient to straighten his back, thoracic extension, and the symptoms increases around the arm. That means thoracic spine is in. And in this case, we have to target cervical and thoracic spine in our management. So repeat movement testing, which is again, it's based on the work of Richard Rosedale, the head of the educational committee of the McKinsey Institute International. There is a link between cervical spine, thoracic spine, and shoulder symptoms or upper limb symptoms. So if you do the repeated movement testing and the symptoms around the shoulder decreases, well done. The problem is mechanical, number one. The problem is spinal, number two. And in this case, the treatment has to be directed towards cervical spine, like lateral glide mobilization, doing any movement that decreases symptoms, do it repeatedly, actively or passively, activating the deep neck flexors, which is very important to maintain the head in position and decrease and minimize the mechanical loading of the neural tissue. If not, we do passive mobilization. Why passive mobilization? Because if we do passive mobilization of cervical spine, like lateral glide, for example, or extension or retraction, it actually improves the neural mobility. It improves the axonoplasmic movement, which consequently will calm down the neural pain around the shoulder. That's mean if you do passive mobilization and the patient's symptoms decreases, A, again, it's spinal, B, it is mechanical, C, shoulder symptoms, part of the problem is related to cervical spine, and our treatment must include some neck mobilization or cervical mobilization, as well as thoracic mobilization, because as you know, the thoracic spine is the base of the pyramid and the cervical spine is the top of the pyramid. So you can't move the top of the pyramid without moving the bottom part, okay? If not, i.e. repeat movement testing and cervical spine mobilization all has no effect on shoulder symptoms, that means the problem is actually a shoulder problem, which is not very common, because if you think about it, what are the common problems around the shoulder joint? Mainly rotator cuff problem or structural problem. And in this case, we need to think about what could be the next step. I think the next step is to think about what might go wrong about the shoulder joint. In case if we rule out cervical and thoracic spine. Problem with mobility, and as I mentioned at the beginning, we have the simple, rhythmic, and gentle mobilization strategies. We have pain, which is related to the joint lack of mobility, and we have problem with motor control. So if you think about any shoulder problem, it will be you can break down this problem into three elements: pain, motor control problem, and problem with mobility. So, and as I said, because most of the time the mobility problem around the shoulder is related to muscle guarding, that's why movement or manual therapy for the shoulder should be slow and rhythmic and gentle and from unloaded position, lying position. All right. So I hope guys you have time. So my colleague Dr. Hayat Mustafa, which is one of the keynote speakers, can do some practical just in 5 minutes to show you this. If not, I will be more than happy to send some online materials with some videos to the conference committee, so they can distribute it to the audience. Okay, now when it comes to motor control, I think we need to make it simple. Just look at the three musketeers. The overactive mobilizers like pectoralis minor and levator scapulae, activating the global stabilizer like serratus anterior, middle trapezius, and lower trapezius, and activating the local stabilizers like rotator cuff muscle, particularly subscapularis. All right. So when it comes to exercising shoulder, to provide patient with shoulder exercise, it's very important to maintain the humeral head in place, because this will decrease the tension on the neural tissues, number one. Number two involves the kinetic chain. So adding lumbar spine or trunk or lower limb movement with the shoulder exercise will add value, because you are adding the kinetic chain. So do the exercise while you are squatting. Do the exercise with stepping up or stepping down. Do the exercise with lunges. And always respect irritability. So don't give the patient to exercise that will increase the symptoms to much higher level than he always have, right? And when it comes to exercising a rotator cuff in particular, it's highly recommended based on the great work from Professor Gelcock from Australia and tendinopathy, that it must include isometric and eccentric loading, but also concentric loading at some stage. So finally, I will finish with this. Doing appetizers or doing the other treatment, as I said at the beginning, the exercise is the main dish that you will all must give to the patient. And then we have the manual therapy. I consider manual therapy as a dessert, because it's sweet, it gives an immediate effect. But also we have to give our patients some appetizers like taping or needling. And again, all this will help the patient to have less avoidance of movement and less fear of movement. It was a pleasure to be with you. Thank you so much. And this is primephysio.com, our website. You can follow up our next activities, and thank you so much. Good afternoon, everyone. Assalamu alaikum. My name is Mahmoud Saad, and it's a pleasure to be part.
That's all about the keynote speeches of this plenary. Thank you for your active listening. Now I would like to invite our worthy co-chair, Dr. Haider Daran, to give his views about the keynote speeches. Please welcome Dr. Haider Daran.
Bismillah ar-Rahman ar-Rahim, and Assalamu alaikum and a very good afternoon to all of you. I will summarize some of the keynote speeches. Ms. Deborah, she presented about the clubfoot, and she was presenting the cases from Zimbabwe. Clubfoot is a common problem in children with this, and which can be treated very simply, but just need a technique ponsity. So she was discussing the method of ponsity. She was also discussing the old method kite, which was used before the ponsity. Ponsity is relatively cheaper, effective, and simple method which could be used for the clubfoot. She also discussed the case, the medical fit collaboration with the Paraplegic Center, which is always there to help the disabled children, disabled people, and they have started working with the clubfoot. There are 7,500 children born with clubfoot deformity every year in Pakistan. Half of them they are getting treatment, while half of them they are left without treatment. And one of the solution, the easy and cheaper solution for them is ponsity method, to be treated by physical therapists by ponsity method. She also discussed the importance of teamwork, training, and those things for the clubfoot. The next keynote speaker was Kamar Mahmood. He was discussing the traditional massage, the effects of traditional massage on spasticity in children with disability, cerebral palsy children. And this is not a regulated massage because there is no curriculum for the massage, but traditionally it is used in Pakistan. And some interesting findings were reported because upper limb was getting improvement after 6 weeks, while the lower limb was getting improvement after 12 weeks. And another interesting finding, the right side there were significant effects on the right side, while there were no effects on the left side. So another areas identified by him for further research. Professor Salman, he was talking about challenges to implementing the AI, and he was presenting a case, a pilot study, where lack of knowledge, training, readiness, probably there were some of the problems identified by the people, but still physical therapists, they want to learn about the artificial intelligence. And the last sentence was quite good, that probably AI won't replace the physical therapist, but physical therapist having AI will replace the old physical therapist. So there was again a warning for all physical therapists who are not interested in AI. And the fourth one, Mahmoud Saad, he was discussing about the shoulder management, and the main crux of his discussion was that it's not always the capsule which is causing problem in shoulder joint. Probably there are many factors which could be causing the problem. So a holistic approach was proposed in his lecture, that we should be focusing on the neck plus on the thoracic spine while considering the shoulder joint assessment. And he was suggesting repeated slowly, gently and unloaded movement while assessing the shoulder joint. Thank you very much.
Now, I would like to invite our worthy co-chair, Dr. Aisha Kamalbar, to summarize the remaining keynote speeches. Please welcome, ma'am.
Assalamu alaikum, thank you very much. I'll start with Dr. Alake, and I hope I do justice to what you've said. So he discussed the role of early intervention and the impact of delayed treatment, not only on the person, but on the society overall. He included the financial implications and the cost effectiveness of certain treatments. Dr. K discussed barriers and shared 11 key factors, and according to him, adherence to these factors and guidelines will result in improved outcomes. So thank you very much, Dr. Alake. The second one that I would like to talk about is Faiza Badar's work, which is a novel and wonderful approach. She discussed the challenges encountered in introducing a dysphagia support group in Pakistan and setting up this group, how important it is to her. She's also discussed the importance of setting up similar groups. She discussed some of the challenges, and some of the challenges that she mentioned are finding the right professionals, recruiting the right participants, the gender-based factor that she discussed, that there's a biasness, funding and resources, the digital divide, need for awareness, and she hopes that there will be similar groups in the future as well, and she hopes to look at any support that we can provide to her in this regard. The last one that I would like to talk about is the one provided by Dr. Humaira Shamim. Another very insightful presentation. She addressed prevailing and advances in speech-language approaches, particularly with adult neurogenic communication concerns within Pakistan. She discussed the current assessment methods, particularly in light of assessments that are in Pakistan. She discussed methods in aphasia and dysarthria, and she also provided wonderful insight into different indigenous resources that can be used, such as the VESMP, VESMP, the Visual Expressive Skills Management Program. These were all wonderful presentations, and thank you very much for all the information that you've provided to us. Jazakallah khair.
Now, I would like to invite our worthy chair, Dr. Ilyas Sayyed, to conclude the scientific session.
All the presenters, the keynote speakers were wonderful. My worthy colleagues, Dr. Heather Daren and Mrs. Aisha Bhatt, they really said what was needed to be said. So I will compensate for the morning session, and I will just say thank you to everyone. Thanks to the entire organization for doing such a wonderful job. And I would like to invite all the expatriate guests to please visit Peshawar. I'll not be with you tomorrow, so I'll be leaving early in the morning. But I would just love to see you guys there, to see something, practical in Pakistan. And thank you all. I'm very thankful. Thanks.
I am thankful to all the international keynote speakers, respected guests, and the participants for this session. Now we will have the next session by tomorrow at 8 a.m. for the oral paper presentation. For that, you can go towards your respective rooms. I know you are all tired and sleepy, so before leaving the venue, you can have tea. Till then, good evening. See you tomorrow, inshallah.